Dr. Daniel Griffin.
And I'm Dixon DePommier.
And today we're going to be discussing seizures.
Ha, interesting.
Well, I will say seizures of medical concern need to be differentiated from benign febrile seizures of childhood that, although frightening, are benign.
Interesting.
And so let's talk a little bit about that.
You're the boss. Go for it.
So like we always like to do is we like to differentiate something that is a primary issue that we can focus on versus something that is secondary to another concern that we need to address. So we'll talk a little bit about seizures. And the one thing that I mentioned as sort of my initial tagline is that seizures that occur during fevers are very common. I would say over 10% of the world's population will have at least one seizure in their lifetime.
What is the temperature limit that induces that, do you think?
It depends.
Oh.
And it depends upon age.
Okay.
But any fever, and it's not the height of the fever that is predictive of whether or not you have a seizure.
I see.
We would think, I mean, the common sense would be like, oh, fever's 101.
That's why I asked the question in that way, but that's
it's
not
101. Oh, they're going to have it's 104. Now I'm sure they're going to have a seizure.
Right.
Not
And they don't
necessarily temperature dependent.
I see.
So it could be 101, it could be 104. But having and that's one of the first questions that ERs will ask, particularly when a child comes in, is when they had this seizure, were they running a fever?
Right.
And because those are benign, they're not predictive of epilepsy, chronic seizure disorders.
Interesting.
It can even happen in adults. Adults can have febrile seizures as well. And so I think that's something to realize. That seizures are quite common.
Throughout the tropical world, that must be very common because malaria is very common and it induces fevers in both children and adults. So you must have a lot of people out there suffering from these kinds of seizures.
Well, we certainly have millions every year. Millions every year having febrile seizures.
That's incredible.
Yeah. So it's important to make that first distinction. Is you had a seizure, did it happen during a fever?
Right.
So that's one question. The next question might be the issue of, is it the first seizure? Have you ever had a seizure before?
Right. And by the way, how do you define a seizure?
That's excellent. So let's start with that. Before we could ask
What's
all these
a
questions,
seizure?
we want to know what a seizure, and is a history reliable? Can a person adequately describe a seizure?
Right.
And so we'll start by saying there are several types of seizures. There's the generalized seizure that people might be familiar with, where the entire body is moving, called these grand mal, or really bad, or generalized seizures, where the entire body is moving. The history might be that the person dropped to the ground, had this event occur, followed often by loss of urine or stool, and then classically followed by a period of time where they were confused. Because you want to make a distinction between a seizure and
fainting.
Syncope.
Well, what is that?
Loss of consciousness.
Oh, okay, that's fainting. Fine.
Because if syncope or loss of consciousness, the person usually quickly orients. They don't have a post-seizure or post-ictal period of confusion. There also can be localized petit mal seizures, where instead of the entire body, it might just be a part of the body where we're having the muscular convulsive activity. And we also can have absent seizures, where the seizure is affecting consciousness, where the person might be sitting there looking off in the distance, unaware of their surroundings. So a seizure without muscular activity.
Wow.
And so those would be the three major types to break down once we're looking at seizures. We want to make sure it's with or without fever. That's critical. And then we want to ask about, was there anything that provoked this? Right. So you tell me this was a seizure, and we feel comfortable that they had the proper presentation, they had the convincing post-ictal or post-seizure cognitive state.
Right.
And then we want to sort of get into what may have triggered it.
Right.
And so alcohol, either excessive amounts of alcohol or withdrawal from alcohol.
Right.
Certain, we'll say, medications or drugs. Drugs can be associated with triggering seizures.
Got
If someone has an issue with sugar levels, hypo and hyper,
of course,
but particularly hypo or low blood sugar can trigger seizure activities.
Exactly.
And this is to be different than epilepsy, which is a chronic neurological disorder associated with recurrent seizures without fever and without any of these precipitants.
Interesting. Do you assume that there can be some genetic basis for some seizures?
So I think that's reasonable. That certain people with seizures, this will be an inherited genetic disorder. But why do you ask?
No, because I have my childhood memories. They're a little faint now because of my age, but I do remember that my grandmother, who happened to be Irish, and her 4 sisters moved to New Orleans when they were young women, and they all went their separate ways but stayed close to each other. And by the time I got to know her, she was quite an old woman. And I can recall at least 2 times while we were visiting that she had a seizure. And the causes of that were not known.
Now, where was your grandmother born? Where did she grow up?
She was born north of Belfast,
Okay.
Northern Ireland. She was a Protestant.
Okay.
So naturally, they moved to New Orleans, which is the 2nd largest Catholic parish in the world.
Okay.
It was kind of weird, but yeah, that's where she grew up as a young woman in Northern Ireland. And then I think because of the potato famine, moved to New Orleans.
Okay. Well, the reason I ask, and this is something I want to make sure we bring up, is there is a certain parasitic disease which is responsible in many parts of the world. Actually, in many parts of the world, is the most common cause of seizures.
This is true.
Which is kind of interesting for a lot of people to realize that here's a seizure, here's a neurological disorder, chronic, but the number 1 cause in many parts of the world is a parasite.
It is, which I'm highly familiar with, but I would like you to describe it.
Well, since you're the expert, I was going to push you in on this.
To defer on this.
But shall we talk about something called neurocysticercosis?
We should.
How does one acquire this?
Well, it's a stage of a tapeworm that if you ingest another stage of that same tapeworm, you get the adult worm itself. This, the neurocysticercosis part, is what happens when you ingest the egg of this parasite. If you ingest the egg of this parasite, it hatches in your body, it circulates throughout the blood until it lodges someplace, where it then grows up to be the larval form of this parasite, which, if you were to ingest that, would become the adult. It's not so easy to understand. So when I taught at the medical school, I actually had a little song that I made all the students sing. And they actually like doing that, by the way. So,
did you want to perform?
Eat the egg, get the larva, eat the larva, get the adult. Eat the egg, get the larva, eat the larva, get the adult. If you remember that song, you will remember how this parasite is transmitted. So what do you eat in order to get the adult parasite? And what you eat is raw or undercooked, infected pork. You don't get neurocysticercosis by eating a cysticercus. Then you get this adult worm. The adult worm is a long, benign worm that lives in your gut tract. It doesn't do much except absorb some nutrients. But it also produces lots of eggs. And if you were to encounter the egg of this parasite, as the pig often does, those eggs will hatch and go to the tissues and develop into this larval form. And that's basically the life cycle. But if people develop this cysticercus stage, it doesn't often lodge in the brain. But when it does, it presents as a space-filling lesion. And it can often, the symptom that is triggered by this infection in humans is when the cysticercus in your brain starts to die. It's not while it's alive that it triggers the seizures. It's when it starts to die and it loses control over your immune system. As a result, your immune system comes down on this cysticercus, much the same as the analogy between that and killing a fly with a sledgehammer, basically. The parasite is already dying. Why does the immune system have to care about that? It doesn't seem to know, and it wants to kill it even more. And when it does, there's an innocent bystander effect it spreads into the brain tissue near this parasitic infection, which can place pressure on various areas of the brain and in some cases induce seizures. In Central and South America, it is the leading cause of seizures.
Yeah.
And when you add up all those people, it's more than all the rest of the people that you just mentioned.
Yeah.
Quite impressive.
Yeah, so I think this is important to know, is that when we talk about seizures as a disorder, in a lot of areas of the world, the majority of time, your patient who presents with seizures, non-febrile seizures,
Right.
non-alcohol withdrawal, non-drug induced, they actually have a parasitic disease.
Yeah, that's exactly right.
And this is being triggered by the fact that these cysticerci in the brain are dying.
Exactly.
And so the treatment may not necessarily, it may involve anti-epileptic drugs, but it may involve treatment of the parasitic disease.
Or anti-inflammatories.
Exactly. So we'll take that. Again, we want to make sure that when we talk about seizures, and now we're going to treat those we identify. And how we can identify, it's not easy.
Not if you don't have sophisticated equipment, that's for sure.
Yeah, there have been some studies done in South America where it's really been shown you need CAT scan and MRI.
Exactly.
So it's a sort of, it is a resource intense endeavor to recognize those seizure patients that have this due to neurocysticercosis and recognize and treat them appropriately, because there's only about a 10-year window from the neurocysticercosis developing in the brain to dying. And if you can get them maybe through that in an expedited manner with antiparasitics, with anti-inflammatories, steroids, with maybe seizure medications, which you might end up needing to do during that window period, you could then bring them out the other side and not have someone who's chronically on anti-epilepsy medicines.
Right. Or have to undergo a very expensive brain surgery operation, which would have had the same effect as if you had given all these other therapies without invasion.
Exactly. So I'm glad we bring that up, and I want people to be attentive to that if they're going to areas where neurocysticercosis is a problem, so that is recognized.
So like Brooklyn.
I rather than your song, I always enjoy the two stories. I enjoy the story of the Orthodox Jewish community in Brooklyn that developed neurocysticercosis, because it reminds you, how would they have gotten it? Well, they don't eat pork, but the people working in their kitchens ate the pork, got the adults, and then the Jewish people were basically getting the eggs from the fecal contamination.
Exactly.
Or the story I tell of it was a Muslim boy who was, he was observant and halal and did not eat pork, but his Hindu house mother and father were doing the cooking. They ate pork, they were infected, and then unwashed hands, the eggs got into his food. So it's not the pork. Pork doesn't give you problems. It's the tapeworm eggs in the pork eater that give you problems.
Eggs, that's the critical point.
But so now we've gotten rid of our febrile seizures,
We have.
our drug and alcohol seizures, our neurocysticercosis seizures, and we're left with epilepsy, which is seizures, not quite understood why. There's a focus in the brain that's firing. And what I'll say for most people that are treating these patients, it's usually good to have a neurologist involved for initiation of therapy. And it's then often that medicines are being renewed by non-neurologists. It's always nice to get a full workup, a really thorough neurological exam, rule out all these other causes. And then worldwide, one of the most common medicines used is carbamazepine. And this will be used in children as young as 5 to 11 years of age, and then adults greater than 18 all the way up.
So allow me to try to stump you with something.
Okay.
Try to
this
distinguish.
Might be bad.
No, it's a good question. I know you'll think it's a good question. I hope. Distinguish for me the difference between a seizure and a patient going into coma.
Well, they're quite different. The coma is going to be a drop of the level of consciousness. Now, a seizure, and we're going to make a distinction, a seizure is going to be one of the three that I described. Now, the absent seizure is going to be like a coma. You can think of it as a loss of consciousness, but it's going to have a certain amount of duration to it.
Right.
It's going to be followed by a postictal. one of the challenges we have is our comatose or non-responsive patients who might be having seizures.
Exactly.
And in a resource-limited place, this could be challenging. If you have resources, often we'll actually do EEGs, electroencephalogram monitoring, to make sure that our non-responsive comatose patient is not in status epilepticus. So that is a concern. Let me talk a little bit. How are you going to diagnose your how are you going to dose your medicines in a resource-limited area? So I want to close by at least bringing this up.
Sure.
So we're probably not going to be drawing blood levels, and we probably don't need to be drawing blood levels. So one of the bits of advice that I'm gonna give people with regard to dosing seizure medications is you want to use the minimum dose that controls the seizures. And controlling the seizures may be a seizure once a year, maybe a seizure twice a year. You're going to have to adjust your thresholds. How do you know you're giving them too many medicines? If you give too much of a seizure medicine, person will start to develop nystagmus, which is a side-by-side jittering. So you have them move the eye to the extreme and see if they have nystagmus. So this allows you, without laboratory monitoring, to see, am I overdosing? Does the person start to get vertigo? Do they start to get dizzy, sedated, nausea? So you want to basically titrate down to the lowest dose that controls the seizures, and you want to avoid going too high and developing all these neurological side effects.
So how do you keep young people from driving that has this syndrome?
So in many areas of the world, this won't be a problem.
but
in areas of the world where there are cars and where the individuals might be driving, usually there are established local rules on how long past the seizure. And if someone's having a couple seizures a year, you've got to ask, is that going to be legal for them to drive?
Exactly.
So some areas require such good control of seizures that there's been no seizure activity in the last year. But you can imagine that doesn't necessarily rule out another seizure should they become a little sleep deprived, etc.
That's right.
So no, that's a big consideration in many parts of the world.
Right.
Okay.
Good.
All right. Well, thank you for joining us for our discussion of seizures.
Yep.
And we look forward to seeing you again.
Seeing you next time.